I'd like to thank the organizers of ESMO for giving me the opportunity to present for you today the ENTRADA study, which is a randomized, double-blind, phase 2 trial of the combination of telaglenastat plus everolimus versus placebo plus everolimus in patients with advanced or metastatic renal cell carcinoma. Here are my disclosures. Glucose and glutamine are key metabolites in tumors, and increased glucose and glutamine metabolism support tumor growth and proliferation. In normal cells, glucose undergoes glycolysis and is further metabolized in the TCA cycle for generation of energy. However, in tumors, cells undergo a metabolic shift where growth factors drive abnormal glucose metabolism. This abnormal glucose metabolism is known as the Warburg effect and deprives the TCA cycle of key metabolites. To compensate for this metabolic shift caused by the Warburg effect, glutamine metabolism is increased to sustain TCA cycle for growth and proliferation. Telaglenastat is an oral inhibitor of glutaminase, the key enzyme for the conversion of glutamine to glutamate. In preclinical studies, telaglenastat in combination with the mTOR inhibitor everolimus inhibited both glucose and glutamine metabolic pathways. Together, they showed synergistic anti-proliferative activity in vitro and enhanced anti-tumor activity in mouse xenograft models. In a phase 1b study of 24 patients, the combination of telaglenastat and everolimus in patients with metastatic renal cell carcinoma who had a median of 2 prior lines of therapy had a disease control rate of 92% and a 5.8-month median progression-free survival, which compared favorably to historic controls. The ENTRADA study is a randomized, double-blind, phase 2 study of everolimus plus telaglenastat or placebo. Patients must have had advanced or metastatic clear cell renal cell carcinoma with a KPS of greater than or equal to 70% and at least 2 prior lines of therapy, including at least 1 prior VEGFR-directed TKI. Patients with treated or stable brain metastases were allowed on protocol. However, prior therapy with mTOR-targeted agents was not allowed. Patients were stratified based off of MSKCC risk score and the number of prior TKIs and randomized in a 2-to-1 fashion to everolimus at the 10 milligram everyday dose plus telaglenastat 800 milligrams twice a day by mouth, or everolimus plus placebo. Of note, everolimus was used at the standard starting dose for everolimus monotherapy in RCC. The primary endpoint was investigator-assessed progression-free survival with a key secondary endpoint of overall survival. Additional endpoints include safety, objective response rate, and quality of life measures. This randomized phase 2 study is to determine the efficacy of the combination of telaglenastat plus everolimus in comparison to placebo plus everolimus by progression-free survival. For the primary comparison, the study was designed with an 80% power to provide a one-sided alpha of 0.2. Using 2-to-1 randomization, approximately 48 events defined as either progression of disease or death was required to detect a hazard ratio of 0.6. In this study, the minimum detectable hazard ratio of 0.77 was possible. The study aimed at 3.7-month median progression-free survival for the everolimus control group based off of published data for use of everolimus in the third-line setting in clear cell RCC. The estimated sample size necessary was 63 patients. The baseline characteristics were typical for RCC patients treated in the late-line setting and well-balanced across the stratification criteria. 46 patients were randomized to the telaglenastat everolimus arm, and 23 patients were randomized to the placebo everolimus arm. The median age of the telaglenastat everolimus cohort was 64.5 years, with a range of 47 to 85 years. The median age of the placebo everolimus cohort was 65 years, with a range of 37 to 70 years. Patients were predominantly male, with 80% in the telaglenastat everolimus arm and 87% in the placebo everolimus arm. Patients were predominantly MSKCC intermediate or poor risk, with 70% in the telaglenastat everolimus arm and 65% in the placebo everolimus arm. For both treatment arms, patients were predominantly treated in the fourth line or later setting, with approximately 2/3 of patients receiving 2 or more prior TKIs. Most patients were also previously treated with PD-1 inhibitors, with 91% in the telaglenastat everolimus arm and 83% in the placebo everolimus arm. Patients had multiple sites of disease, with 1/3 of patients having bone metastases. The combination of telaglenastat plus everolimus demonstrated an improved progression-free survival compared to placebo plus everolimus, with a hazard ratio of 0.64 and a one-sided p-value of 0.079, and met its primary pre-specified cutoff of 0.2 for progression-free survival. In the telaglenastat plus everolimus arm, one objective response was seen, and 56% of patients had stable disease. In the placebo plus everolimus arm, 48% of patients had stable disease. The combination of telaglenastat plus everolimus demonstrated this improvement in progression-free survival with a median follow-up time of 7.5 months and a minimum follow-up time of 3 months. The median progression-free survival in the telaglenastat plus everolimus arm was 3.8 months, whereas the median progression-free survival in the placebo plus everolimus arm was 1.9 months. Subgroup analysis by age, sex, race, performance status, number of prior TKIs, MSKCC risk stratification, and prior PD-1 directed therapy did not clearly identify any subgroups of disproportionate benefit. However, the trial was not powered to detect any differences within these subgroups. Treatment emergent adverse events leading to drug discontinuation were similar between the arms, with 28.3% in the telaglenastat plus everolimus and 30.4% in the placebo plus everolimus arms. Dose reductions or interruptions of either drug were seen in 76% of the telaglenastat plus everolimus arm and 61% of the placebo plus everolimus arm. Overall, the combination of telaglenastat plus everolimus was well tolerated, and severe adverse events were similar to that of everolimus plus placebo. Few additional grade 3 or grade 4 toxicities were seen in the telaglenastat plus everolimus arm compared to that of the placebo plus everolimus arms. This randomized phase 2 trial demonstrated improved progression-free survival for telaglenastat plus everolimus versus placebo plus everolimus. Patients were heavily pretreated with a median of fourth-line therapy, and most patients were refractory to multiple TKIs and checkpoint inhibitor therapy. At this time, the secondary endpoint of overall survival is not yet mature. Telaglenastat plus everolimus had a tolerable safety profile in this study. The Entrada study supports proof of concept for telaglenastat and supports glutaminase inhibition as a new therapeutic strategy for metastatic RCC for further study. Currently ongoing is the Cantata study, which is a large, double-blind, randomized trial of telaglenastat and cabozantinib in comparison to cabozantinib plus placebo, which will further investigate this mechanism of action in combination with VEGF-directed therapy in the second and third line setting. We'd like to thank all the patients and families who were integral to this challenging disease. We'd also like to thank the study teams at all the participating centers, and I'd also like to thank you for your attention.